Bismillahirrahmanirrahim. Assalamualaikum dan selamat sejahtera. Selamat pagi kepada semua. Terima kasih kerana menghadiri. Thank you for attending the CPC conference. Okay, we will start first with Ummul Kitab Al-Fatihah. Okay, so the topic for CPC today is regarding a young patient who actually unsuspectedly came to our emergency department footsteps with symptoms of stroke. So this is kind of rare, so we kind of discuss. So our panelists today will be first our emergency registrar, Dr. Changgita Arumugam, who will present the case, and thank you for attending. And then the next panelists will be Prof. Shahizun Azura Mukari, because presenting, and she will be presenting and elaborating about the CT scan and findings that and the MRI findings of the patient. And she's actually consultant radiologist who have interest in neurology. And our third speaker and panelist will be Dr. Wan Ashraf Wan Zaidi, who is consultant neurologist and also involved in the stroke team, and he will be talking about this young stroke patient which we have managed. Okay, without wasting further time, I would like to introduce and present Dr. Changgita to present her case.
Okay, good morning all. I will present on this case that came to us earlier. So the patient that came to us, our earlier diagnosis was young stroke, so we'll discuss on it. So this patient presented to us on 27th of August at 4 p.m. We received a young patient presented with complaint of sudden onset of slurring of speech since 1:45 p.m. while he was at school. So he reached us within 2 hours 15 minutes of his presenting symptoms. He had sudden onset of blurring of vision on bilateral eyes, followed by right upper limb and lower limb numbness and weakness. It was associated with headache and he vomited ×3. Slurring of speech occurred next. Otherwise, he had no chest pain, no SOB or no fever. Patient actually had history of slurring of speech 1 year ago, which lasted for about 30 to 45 minutes, but they did not seek any treatment. From the view of the patient came within 2 hours 15 minutes with complaint of weakness and slurring of speech, stroke call was activated and CT stroke protocol was requested. For further patient's past medical history, he had history of hydronephrosis during neonatal. He had history of inguinal hernia repair 2007, and currently he's a Form 1 student. In family history, we noted that the father has history of minor stroke at the age of 38. Upon review in emergency department, patient was alert, conscious, there was no more slurring of speech. Pupils bilaterally reactive, no nystagmus. There's no cerebral sign, cranial nerves were intact. Vital sign was BP slightly highish on 150/78, pulse rate of 110, SpO2 100% under room air, temperature and DXT was normal. On neurological examination, we noted power over the right side at shoulder, elbow, and wrist region was actually reduced to 4/5, but within 5 to 10 minutes of assessment, power returned back to normal at 5/5. But the reflexes were normal, 2+ bilaterally, Babinski was ongoing. NIHSS score was done by neuromedical team and it was 0. Thus, we proceeded with the CT brain. It actually shows ill-defined hypodensity involving the grey-white matter noted at the posterior left temporal lobe with effacement of the adjacent sulci suggesting of the acute infarct. While defined, there is also well-defined hypodensities at the anterior limb of the right internal capsule, posterior limb of the left internal capsule, and left occipital lobe. CTA showed reduced cerebral blood perfusion, and also volume at the left posterior temporal lobe. Patient was initially started on TAP aspirin 150 mg and also TAP atorvastatin 40 mg with plan of admission to ward for further workup. Working diagnosis at that time was young stroke, and the differential that was given was cerebral vasculitis. While patient was in the ward, the investigation of vasculitis was done. Viral screening was negative, ANA and TDS DNA was negative, TSH-T4 normal, ESR level of 8, folate vitamin B12 normal, Coombs test was negative, RP and LFT all remain normal. On 28th of August, they proceeded with EEG. There was focal slowing in the left occipital region in keeping with the known structural abnormalities. Transesophageal echo with bubble test was also done, which shows normal chambers. Noted septum was intact, no ASD, PFO, no color flow across the IAS seen. There was no bubble to cross IAS to LE. There was no other further episodes of weakness or numbness or seizure during the stay in ward. MRI was done later on the 7th of September and the impression is normal. And currently, patient is still under neuromedical follow-up during their last TCA in October 2020. The impression is to rule out MELAS, mitochondrial encephalopathy, lactate acidosis, stroke-like episodes due to stroke-like episodes, and also EEG actually showed left occipital focal slowing. The investigation has been sent for MELAS, but is still under process. That's all. Thank you.
Okay, thank you, Dr. Changgita, for the presentation. Okay, we wouldn't know MELAS for the first time the patient came into the emergency. That was after a while. So the next panelist will be Prof. Shahizon, and she will be talking on the CT scan and radiological investigations that was done on this patient. Okay, so I'd like to invite Prof. Shahizon.
Okay, thank you very much, Dr. Nick. I can't seem to start my video, so you won't be able to see my face. So I'm going to start sharing my screen. Right. So, Assalamualaikum and a very good morning to everyone. Right. So on the 27th of August of this year, we were alerted of a stroke call. A request came in to basically image this 13-year-old boy who presented with right-sided body weakness. And this was the request that was posted through our CHETs with the clinical detail as shown. So with this kind of presentation and referral, especially to look for right-sided body weakness, there are a few causes that has to go through our mind. In a patient who comes in with acute hemiparesis, we have to rule out stroke or the stroke mimics. And the first imaging modality that is usually done would be that of a plain CT. If you look here, the window level and window width, this is a default window setting that is available when you are viewing the images on the MedWeb. And from here, I think,
sorry, Prof, on kan video, Prof, off video tu.
Oh, okay, tadi tak boleh. Okay, now. Okay, now. Can you see? Okay, kejap .
Boleh.
Boleh ya? Alright. Okay, now This is the plain CT. And from here, what do we look for in an acute stroke? Would be that of an area of hypodensity involving the basal ganglia, the lentiform nucleus, as well as looking for any loss of gray-white matter differentiation with presence of hypodensity. So in this patient, if you look at the entire brain, there is no obvious hypodensity that is seen. The gray and white matter differentiations are essentially normal. Even the deep gray matters are all normal. And the other sign that we look for would be dense vascular sign, dense vessel sign. And the commonest vessel which is involved usually will be the MCA. And here again, everything looks just normal. But in a patient who comes with acute hemiparesis, sometimes a very subtle hypodensity can be missed on the default windowing and window level. So one way to manipulate the image so that distinction between the gray and white matter is clearly seen is by playing around with the window width to a value which is similar to the window level. This is what we call stroke window. So this is how it looks like. And here I hope you can appreciate that the entire gray and white matter is clearly better seen. And from here, you can see the distinction is clearer and there is no involvement of the cortex, the gray matter. Everything looks just normal. So basically, this is essentially a normal CT brain. And in a stroke case, we would usually evaluate the aspect score for the anterior circulation, and this would be an aspect score of 10. Because this was a stroke protocol, we proceeded with a CT perfusion. And what it does is basically to evaluate the perfusion in the brain parenchyma. So the machine will do all the calculation, and the parameters that we normally would look for would be the MTT, CBF, and CBV. MTT basically is done to look at the average time that the blood spent in the brain parenchyma, while the CBF is the volume of blood within the that flows into the brain parenchyma, and CBV is to assess the volume of blood within the brain parenchyma itself. So in this patient, if you look at where the arrow is pointing, you can see that there definitely is an asymmetry of the MTT, meaning that there is a delay in transit of blood in the brain parenchyma itself, as shown here. And you can see, if you compare onto the contralateral side, that the area in the left frontoparietal region has shown a reduction in CBF and CBV. This indicates that there is an element of hypoperfusion. We see this all the time with acute stroke, and usually it would involve a large vessel occlusion. But I hope that you are very familiar with all the arterial territory, as an acute ischemic stroke normally would just involve one vascular territory. But in this patient, note that it involves the MCA as well as the ACA territory. So this is not a clear cut or a simple acute, it would rule out acute ischemic stroke, and we have to think of a stroke mimic as a cause. This is further supported by the absence of large vessel occlusion. All the arteries are all normal without any evidence of occlusion. Okay. So in summary, for this patient, we have a boy who came in with a normal plain CT. There is no evidence of an acute stroke, early stroke. One of the signs that we look for would be a dense basilar sign, which is absent here. The only abnormality is the CT perfusion, where you see that there is an increased MTT with reduction of the on CBF and CBV, but it involves two vascular territory, and the CTA, which basically show no large vessel occlusion. So with this kind of finding, we can safely rule out acute ischemic stroke or hemorrhagic stroke. And we have to concentrate, and we know that we're dealing with a stroke mimic. We can exclude space occupying lesion. So these are the differential diagnoses that one would have to bear in mind, especially in pediatric or in young adults. Okay. So MRI was done about 10 days later, basically to further evaluate and look for any evidence and signs of mitochondrial disease, especially MELAS. What we saw was that the brain, MRI brain was entirely normal. This is a T2 weighted image. You can see that the distinction between the gray and white matter is normal. There is no abnormal high signal intensity on flare. And the DWI and ADC, which is a very sensitive sequence to look for a recent infarct, does not show any restricted diffusion. We also did a couple of more advanced imaging. MRA, again, did not show any large vessel occlusion. We did MR spectroscopy. This is a sequence that allows us to measure metabolites in the brain. And for MELAS, we normally would see a lactate peak. And we see that at around 1.3 ppm, but here it's just flat. So we don't really see any lactate peak in this patient. This color-coded image is arterial spin labeling. Basically, this is just MR perfusion, but without contrast. And if you remember what DCT perfusion showed earlier, where there was an area of hypoperfusion, this ASL did not show that abnormality. It has returned back to normal. It is all symmetrical. So now, of all the differential diagnosis for MELAS, one would expect that the patient would have variable infarcts of different ages, especially involving the cortical area. So in the MRI brain, we should see an area of recent infarct as well as an old infarct, which is absent in this patient. And the MR spectroscopy did not show any elevation of lactate peak, which is typically seen in MELAS. And the MR perfusion also show hypoperfusion, when in MELAS one would expect a hyperperfusion. So now we know that we are dealing with something radiologically which is reversible, and the two commonest possible cause would be that of hemiplegic migraine or post-ictal paralysis. But we need clinical information and to be able to reach to this diagnosis. Okay, so these are the two possible differential diagnoses for this patient. Thank you.
Okay, thank you very much, Prof, for the very interesting and very informative description on the CT scan and MRI. Okay, I'd like to pass this to Dr. Wan Ashraf for further management of the young stroke.
Sorry. Assalamualaikum. Thank you, Dr. Nick. Can you see my slide?
Yes, can see.
Okay. So I continue.
Yeah.
I think quite easy for me now because of it's already well illustrated by the first two speakers. So just to share over here, we're going back to the history. Maybe there's a bit of lacking here, but we go back. So just to share on the left-hand side is something that we developed back in 2016. We launched this. This is stroke risk meter. In the stroke risk meter, there's also called stroke detection acronym. So in the English form is basically FAST, face, arm, speech, and time. So in this case, you see that we use muka lemah, angkat tangan, tutur, dan angkat telefon. So that's mata. And below there is a called less frequent, not rare, less frequent presentation of called stroke, for example, posterior circulation, but it can happen. So going back to the history of this patient, this is a young boy, so at the age of 13 years old. We already listened to the history just now. So you know that in this case, the stroke activation was activated, stroke activation or code stroke was activated. And at the moment, reperfusion therapy is basically mostly being studied for the age of 18 and above. But bear in mind, there's emerging data or registry about safety of treatment in the age of less than 18 years old. But for example, RTPA, the dosing, we are not too sure yet. So there's a study ongoing. But thrombectomy, for example, there's more and more data that is actually safe as in the adult subgroup. So this patient came in with a typical negative symptoms. What are negative symptoms? So sudden onset, right upper limb numbness and weakness, and slur of speech. So these are all negative symptoms. Weakness. So compared to the stroke mimic, for example, just now we have seizure, we have possible migraine. So we know that migraine can develop numbness. So there's negative symptoms. So it can be a stroke mimic. However, seizure most commonly present with positive symptoms. But again, in medicine, it's possibly present with a negative symptoms. But if you notice just now, Changgita presented, this patient also have another two symptoms, also another negative one, which is visual defect. So this boy unable to really show to us, which is expected at this age. But we expect with the lesion that we have just now, there's this is left-sided lesion, or maybe there's right-sided homonymous hemianopia. If this were to be a stroke, or there's altered sensorium because of that the optic pathway will be crossing the temporal lobe. Okay, so but there's a positive symptom which is a bit odd with stroke when you have lots of nausea. So for example, without headache. So these are the things which may trigger. This is a stroke mimic. So the duration is 2 to 3 hours, and when when the patient come within 2 to 3 hours with this age, so that despite being young, and if this were to be with classic nausea, slur speech, and weakness, which is significant, and that lacunes in this case, hypertensive lacunes, which is not that common in this younger age. Usually they have more like dissection, large vessel occlusion, or stenosis, but that's rare. So in this age subgroup. So, and resolve 100%, dissection maybe. So that's why stroke activation, I would say in this case, was definitely something worthwhile to be done. So it's actually correct. So just a bit of homework over there for medical students and internal medicine from this slide. If at this juncture, the diagnosis maybe this is a transient ischemic attack. And we do stratify this patient according to ABCD2 score, which is most likely will be low because of his age and his presentation, basically just the preclinical presentation, and also the timing will be his risk factor. Yeah, so maybe 3 in this case. So on examination, again, the blood pressure, something that may trigger you, this is a real stroke because of the blood pressure was high for his age, 150/78, and heart rate was 100 beats per minute, but regular. NIHS is 0. NIHS is basically like a GCS for neurologists, stroke neurologists. We do this. It's a surrogate of full neurological examination. But if I were to attend the same patient, if the NIHS is 0, it didn't mean there's no stroke. We do full neurological examination at the end of this NIHS. We just confirm everything, make sure. Some will say that make sure that the patient will able to walk as usual, and to the extreme of if the patient able to climb a tree, so then ask them to climb a tree as usual. So what is the reason for the BP to be high on the higher side? For example, in seizure, there can be sympathetic stimulation, and during the seizure for a while, just transient. So that's the reason why the blood pressure will be on the higher side, other than the environmental factor, for example, anxiety, everything, because of the activation the stroke activation itself will look very dramatic at sometimes. So on the right hand side, just to share with all, we already have this for quite some time, called, I think, Prof. Nafisa, called Dr. Ramesh, and Prof. Tan. Back then, we have called our dedicated NIHS called scoring leaflet. Okay, and we assess the patient via clinical, and the next one is we need to have a very immediate stroke protocol scan. So as mentioned by Prof. Shahizon just now, a simple CT scan plain, this is the basics. Even for the medical registrar, they need to know that the CT how to interpret a CT scan plane. Then we have CT perfusion, and as mentioned just now, so basically it's not vascular territory. So I put down here, you can see down here, this is a vascular territory, cross the gray-white matter, this is MCA. But this patient just now, it crossed MCA, PCA. So in this case, it's not a classic territorial area. And in most hospitals, called to share with everyone, they don't have called on the, if you can see my cursor, the time to peak and also delay time, which is more sensitive compared to the mean transit time. So as you can see from here, it again clinched the diagnosis, which is not territory, because of it didn't cross again a proper territorial called area from the TTP and the delay time. And as mentioned by Prof. Shahizun before, so you need to check the CTA. So the minimum in most center in Malaysia, by right, there will be CT scan, plane, and a CTA, because of most center in Malaysia will not be able to do CT perfusion as what we did. So there's no vascular occlusion. So in this case, we can relax the stroke protocol. There's no indication for RTPA again, because of this lack of evidence. We don't know the dose. And thrombectomy, obviously, there is no indication for because of there's no large vessel occlusion. So going to, we already have the history just now. We already have examination. We have a good imaging. Now we need to then look back at our knowledge of possibilities now. So that the differential diagnosis should come early, basically, for the medical student. So, but now for the sake of presentation, you already assess everything. So you should have the differential diagnosis just now to share with you. Han et al. Published in 2006 in stroke. So you can see there's a lots of causes of stroke mimics. And one of the most common presentation of stroke mimics is basically seizure, okay, sepsis, okay, toxic metabolic encephalopathy, okay, space occupying lesion, syncope, okay, delirium, okay, and other called differential diagnosis. So include migraine. So in other studies in registry, so as high as 25% stroke code can be called wrong because of lack of neurologist expertise during the pre-assessment. However, this is largely relevant in our center and throughout Malaysia. So neurology screening in another study shows that it can reduce down to only 5% false alarm or stroke mimic. And however, this is basically, again, we need to tell the authority, we need more neurologists to be trained and maybe stroke physicians, okay? And after assessment, immediately during the clinical assessment and imaging, a code stroke can be re-triaged. So I did tell my team and also the emergency department EPs, so we can then re-triage because of we know that we have lacks of resources to continue to manage as this is a non-stroke patient. So important to emphasize, stroke is a medical emergency. So this the one that being activated over here is a good example. This can happen, but it is something called standard. This is a standard of care that should be done for all stroke patients. History examination in this case are very important. It's very easy to go retrospective. The one that I told you just now. So there's a bit of nausea, and this patient is basically on further history. This is not the first time this patient suffer the same symptoms. Okay, so as you can see, because of we do rapid assessments, balance between time and the clinical outcome of a stroke. Because of we need to know that every single minute pass, there's actually 2 million neurons at risk. Yeah? So, and every single hours of delay, the brain can basically age by 3.6 years. Okay, so just to share with the progression in the during the admission history, again we managed to get more history. This is not the first time. So he had another one called a year before. And EEG, as called, if not mentioned just now, there's a left temporal occipital focal slowing, which is concurring with the the perfusion imaging just now. And MRI brain, as been mentioned, so there's no the indication is basically we suspect a focal lesion. We suspect there's no focal lesion in this case, but we suspect a focal lesion. MRI brain in this age, especially more, the current studies basically shows that we need to proceed for MRI brain. And the diagnosis at the moment, we should be wary about there's a possible focal seizure. And for hyperacute sake, this is a stroke mimic. So this is I think my take for this case. Yeah. Back to you, Dr. Nick. Maybe question and answer after that.
Okay, thank you very much, Dr. Ashraf, for the very detailed and good explanation about the young stroke. So I'd like to open discussion to, I saw a few hands up just now to ask a few questions. So you can ask questions to any of the panelists.
Or we can go through the question. I think there's Prof. Wong asked about whether fundoscopy findings in casualty, I think, was not done. But if I'm not mistaken, there is called ophthalmology consult being done.
Okay. Usually, fundoscopy is not done in emergency for stroke, and because of the urgency of that, and also we didn't have enough capability, the location to do the fundoscopy for that patient, and it's usually not in our protocol. Usually, our protocol is that we will inform the stroke team as early as possible if there is the signs of stroke, any pronated drift, all the things that has been mentioned by Dr. Ashraf. Even though we've also activated nowadays is pre-hospital, and then we come and then we stabilize. Our role is to stabilize the ABC, and for fundoscopy, probably usually it's done later on at the moment. Okay, thank you. Any other questions? I think I had some from the participants. Any questions?
Thing we have here is it common to diagnose MELAS, and what is prevalence in Malaysia, and who are at risk to get it? I call basically if this were to be from the medical students, so MELAS is not a usual thing that we will ask you. So, but this is called it's a stroke-like syndrome, and this is one of the variant of mitochondrial disease, and it is not common, but as called if the stroke-like syndrome happen in young, so we need to have a differential diagnosis of this. Usually it's familial. However, the penetration, meaning clinical presentation phenotype, is not 100% in the family. So it can they call varies from one to the other. So yeah, so it's a genetic disorder. So it's yeah, that's a who at risk. Yeah, it's genetic disorder.
Okay, thank you very much, Dr. Ashraf. There's another question here. If the patient were to present with an ischemic stroke and a large vessel occlusion, how would it be treated? No role for TPA. Okay, again, as we mentioned, the patient with stroke symptoms and things, we will inform the stroke team, and will be done a CT scan, CT perfusion as urgent as possible. And if there's no signs of any infarct and it's early stroke, we can still, it depends if we can still proceed for the RTP. So maybe Dr. Ashraf wants to add on the for that.
Okay, so if the patient was presented with ischemic stroke and there is large vessel occlusion, I would say the best is basically at the current clinical registry shows that thrombectomy is safe, and that's the reason why I think the stroke protocol was necessary. And that's I would say that we are not too sure the dosing for our IVR-TPA in this case because of he's still called not really adult age. Yeah. Okay.
Okay. So it all depends on the condition of the time and the presentation of the stroke. So if either we do RTPA or maybe if it's already late and ischemic, then we usually go on to do the medical referral and we continue with the same. If there's no bleed as usual, we will start aspirin, and there's bleed, then we will have to refer to also the neurosurgical team. Okay, the next question is demyelination disorder, not in the differential diagnosis. Okay, again, Dr. Ashraf, you want to comment on this?
Okay, thank you, Prof. Wong, for the call mention. I would say demyelination basically should be one of the differential diagnosis too, and we do. That's the reason why I would say it's necessary to have a further MRI, especially in this subgroup called young stroke-like symptoms. So as mentioned by Prof. Shahidun just now, basically there's no demyelination called changes from the MRI, and we should then follow up on the clinical symptoms.
Okay, there's one more question. May I know, is this a case of thoughts paralysis? Okay, so Dr. Ashraf wants to comment.
That's a very good comment there. So yeah, so basically it is possible. So that's the thing. So thoughts paralysis is basically it's a post seizure paralysis. So you need to ask further whether the limbs involved or the site involved was basically concurring with the seizure site. In this case, it was. So then it is most likely possible. Yeah.
Okay, thank you very much, Dr. Ashraf, and also Prof. Shahizun for the input. Okay, so we can proceed to the questions, MCQ questions for the MCQ questions. Okay, so we go to the first question. We actually look at the scenario just now. It's a different scenario from the case presented for the undergraduates. You have a 25, a young also patient came in with stroke symptoms, and the points here is well, patient has hypertension, diabetes, and pulse was irregular. So this question is more on the management emergency department. So I can see 56% or 52% wanted to alert the stroke team. Okay, so that's actually the first thing we do. Following, other than that, we stabilize airway, breathing, circulation, and everything else which is very urgent. But most urgent also should be done early is to alert the stroke team. So we have also worked with Dr. Ashraf to try to alert stroke team even in the pre-hospital setting, so that the faster time door to needle time for stroke, earlier thrombolysis will give a better outcome. Okay, I can see another one is a request for urgent CT. So this is one best answer. Also, that's also not incorrect. I mean, you want a request for urgent CT, it comes with the stroke team as well. But what is more important to be done first is the stroke team. And then, well, we can also arrange for the urgent CT at that time. Actually, the time actually is not only simply just ordering CT. It includes the time of the ambulance to come, and the time of the transport to the CT, the time of informing the radiographer and getting CT prepared. That's all the time is taken. So actually, it should be done early as well. But the answer will be alert the stroke team will be the first. Okay, so we see the second question is that what is the likely initial diagnosis? You can see that. Okay, acute stroke is 58%. So in comparison to this case that's been presented in CPC, this scenario didn't mention that the patient actually resolved. So for that scenario initially, maybe you can say that it's TIA because patient resolved, but this one we didn't mention that the patient resolved. So initially, what is important, we must think at emergency is that it's acute stroke, because if the patient still have symptoms and we think, well, maybe patient presented early, 1 hour, we think it's TIA, then we wouldn't be as urgent as acute stroke. We wouldn't inform the stroke team. Maybe we will send for CT scan, maybe we'll take bloods. So every time the patient comes in and there is still a symptoms in emergency, we have to think it's acute stroke first. So then we can alert the stroke team and then we can order CT scan urgently, because what is important is time. But if the patient came in and resolved, everything resolved, we will still inform the stroke team, but then we can say it's TIA. But in this scenario didn't resolve. Okay, we see the next one is what is the most likely cause of the above scenario. I can see 52% answered as cardiac embolus. Okay, so usually you will have a clue in that question. You can see the pulses were irregular. Okay, so that's the. Okay, so I can see the other answers also been selected by few students. For example, excessive discharge of a neurogenic foci. Okay, so that one will be more like epilepsy, so epilepsy pathophysiology. So, well, I said this scenario is not the same with the CPC scenario. So it's important for students to get knowledge and then also try to apply, see whether it fits with another different scenario. Okay, but it's not incorrect. It might be, but the best one for that scenario is cardiac embolus, because you can see the irregular, and there's no history in that scenario that is patient had fits. And well, I can see 26 answer mitochondrial abnormality. All right, so it's usual. That's the usual problem as a medical student. You wanna go for more rare cases, because you just learn from the CPC, and it's good, but actually it's a bit incorrect to diagnose this first as your first choice of diagnosis. So it might be, but as I mentioned, this patient is still young, but not as young as the scenario. What's not a school boy, is still 25, 30ish, and there is a history of hypertension and diabetes and irregular pulse. So you must think of most common disease first. You don't just maybe go to the textbook and you can see the most weird case or weird things, and then you will remember that as the first. That should not be like that. So we should go for the more common. So poor glucagon response is I see 9%. Well, that might be as well, because patient has diabetes, and we didn't mention in this scenario that what is the sugar level. So one of the nasal stroke mimics that we can usually get in emergency also is hypoglycemia. So what we do is usually before even alerting the stroke team, we take a Dextrose stick. So that's even faster than doing CT scan and getting a good result. So we take the Dextrose stick, and if it's low, we give glucose. And then if a patient resolve, then we will think more of it might be a hypoglycemia. That could be another, but the answer here is because of the cardiac embolus, which I see a bit more than half of the respondents answer, 55%. Okay, so I think.
Tanik, if I may.
Okay, any comments?
I just want to add. So basically, the classic metabolic risk factor that we have so far, from my experience, diabetes. We have the youngest one is 24 years old. that struck out, that we managed to basically treat properly, and he ended up with a good outcome. Obviously, the young ones, they arrive early. And just to share with everyone, when we say stroke team alert, is basically, actually the stroke team is alerted even not only called when the neuromedical or medical team being alerted. A stroke team in a hospital is basically from the emergency department, neurology or medical, radiology, and also interventional radiology, and even anesthesiologists. That's for the code stroke or hyperacute stroke protocol. So all of these team members are the stroke alert team. so that's the unique part of treating a hyperacute stroke, where it's actually a teamwork rather than called a neurologist cannot survive alone. Yeah. Thank you.
Okay, thank you very much, Dr. Ashraf. Yes, when we say a stroke team is actually when we it's like a simple way or a faster way to alert the whole team. I mean, probably we have to need a radiologist, we need neurologist, anesthesiologist. So in emergency, we need to have teamwork and another way of how to alert many people at one time. So that's the role of women by time, like a trauma team, like a stroke team. So we don't need to page or refer one by one, and that will take more time. So thank you, Dr. Ashraf, for that input. So is there any other questions? Or okay, we see the question is answered. Okay, any other questions on that? Okay, see, how is this patient managed, doctor? Okay, so I see one more question. How is patient managed? From the emergency part, usually the patients come in. Either the patient is came by ambulance or came by itself, and then we will alert. Where patient will come to the triage center, and any symptoms of stroke we will straight put to the resus, the resus zone. Whether patient will be thrombolized or not, things like that, the patient will straight be alerted to the resus, and then we will manage the airway breathing circulation and look at the vital signs, and we try to manage that. So the stroke team will be alerted. And how is the follow up of this patient? We can maybe you can ask give the mic to Dr. Ashraf. How what is the next management of this patient?
Frankly, this patient basically we as mentioned just now, as Changgita, we actually initially wanted to wait for the MRI and also for the MELAS workup. But looking at the final diagnosis, as Prof. Shahidul mentioned just now, in MELAS, the CT perfusion, and even when we do a MRS just now, there should be a further clue about MELAS. So in this case, there's none. So the high likelihood in this case, this were to be called seizure. So in this subgroup, then we are thinking about epilepsy because of there's no other provoking factor in this boy. Yeah. Yeah.
Okay, thank you very much. What is normal range for Dextrose 6? Okay, so usually while we take Dextrose 6 in patients who is unconscious or any of the stroke symptoms is to rule out hypoglycemia. It's just that for some patients with diabetes, say that is hypoglycemia will be a bit higher up. So usually we see hypoglycemia in Dextrose 6 or 3 or 4, but sometimes in 6 also you can see if patient is diabetic and used to very high sugar, we can still, and with symptoms of unconscious or maybe stroke symptoms, we can also think of if it's around 5 or 4. But usually it depends on if it's fasting or not, the patient. I say if it's around 3 to 4, maybe 5, or lower than that, we will say we will put more on the hypoglycemia in the scenario, and we can treat for that. Okay, so. Okay, the next is, what is the next plan of management after alerting the stroke team? So for emergency department, as I mentioned, we try to facilitate whatever the team comes, and we try to facilitate. We will we'll inform the radiology, we stabilize the patient and see whether patient needs any, as I mentioned, any airway breathing circulation management. And also important is monitoring. If the radiology, with the CT scan patient, we facilitate the patient to go to the CT scan as fast as possible. And if thrombolysis has been done, we always have to monitor the patient, the vital signs, the GCS for the patient as patient is in the ED. Once we've taken over, once the patient has left the ED, then another team will fully manage. But the patient in ED is actually co-managed between different teams and different specialty. Okay, so all right. Okay.
Just a bit add on about the management. When I first started, people will ask why not direct to CT. Actually, the one that we are doing now in emergency department, if you can Google it up in YouTube, HCTM stroke activation. So you can see that one is basically standard like any other international stroke centers. So the EPs, emergency team, will assess for ABC, airway breathing circulation, meanwhile waiting for the stroke team to come. So the stroke alert is basically to see whether we can reperfuse, whether IV RTPA or with thrombectomy. If there's none, then we're medical therapy. If it's not a stroke, then we re-triage to medical team. So, and this will be done within 60 minutes preferable. Most of the time we achieve about 90 minutes. So this is a very rapid process. So as I mentioned again, the teamwork allow us to be successful as such. So this is a very fast process each time a stroke patient comes.
Okay, thank you very much, Dr. Ashraf, for the additional information, knowledge. Okay, so is there any other questions we can entertain for today?
Turn back the camera.
Dr. Nick, you're mute. Dr. Nick, you need to unmute yourself.
So, any comment from Dr. Ashraf? If there's, because what we did last time was before there was a stroke team was a bit slow. Any patient with symptoms, we will do a CT scan first, and then we will see the result of CT scan. If there is infarct, we will refer to medical. If there's a bleed, we will refer to neurosurgery. That was what was done previously. Previously, before there was a stroke team.
I didn't get the initial part of question because of you mute just now, but I assume that you are asking about the old version where we do scan first, then the stroke activation will be happening, right?
Oh, the question is what is done if it's a district hospital where there's no neurologist?
Oh, okay.
So I'm just assuming as from my experience before the stroke team, but I haven't had experience working in any district hospital yet. Okay, thank you.
I would say our consensus from Malaysia Stroke Council is basically to simplify things. So if, for example, in a district where there is no CT scan done, so we hope in the future is to collaborate with the EPs, especially the one that are controlling the call center, to direct or divert the ambulance which with suspected stroke to the nearest CT capable hospital, at least a CT scan plane. So that's the aim for the future. And basically this will require, as what we have here in UKM, a multidisciplinary approach. So that is what we hope. So for the main hospital, for example, we did help Hospital Temerloh, and in the future we will help Hospital Angkatan Tentera Tuan Komizan. So we hope that at least they can do CT plane minimum, or CT scan plane with a simple single phase CTA, which is very, very simple. So before they refer to us. So but the consult is as simple as fast. So if they call screen with fast, it is a stroke, then they can just consult immediately. So just to share maybe a very interesting consult, I have a called junior MO calling me from the emergency department from one of the nearest public hospital. So it's a very short conversation. He just told me, called a 32 years old guy playing futsal, right-sided called hemiparesis, seems to be confused. So, and I lead him with fast. So face is weak, yeah, it's weak. Is that call seems to be weak too, and called the speech he unable to assess. So that's why he says confused. So then I told him, okay, you can send to HCTM. So then I put down the phone. So after about 2 minutes, he called me again. Are you sure that I can transfer the patient? I said, it's a stroke. Why not? So while preparing for the patient to go to ambulance, he again texts again. Do you need anything else? So I said, I don't need anything else. I just want you to send the patient. So as simple as that, in short. So if a stroke, most doctors can diagnose stroke by clinical. Yeah, you just can send directly. Yeah. As simple as that.
Okay, thank you very much, Dr. Ashraf. So, if there is a pre-hospital patient is responded by ambulance, so we can direct to a stroke center. But if the patient comes to the emergency doorstep with in a hospital where there's no stroke capability or there's no CT scan. If there's CT scan, maybe we can still do a CT scan, and maybe we can inform the nearest neurologist. But if there's no CT scan, if there's a detect of stroke, so it must be directed straight away to stroke capable hospital. Okay, thank you very much. So, yes. Okay, we see there are two more questions. One more thing I would like to confirm. So every patient with stroke-like symptoms, we have to alert the stroke team. Okay, so I will answer on an emergency point of view. So it depends on the time as well. Patient comes in with stroke for for 1 week before, then we wouldn't inform the stroke team yet. 1 week history of stroke. If it's still within that window of thrombolysis, or maybe when we can actually do angiogram, or maybe you can extract the stroke, or maybe whatever, we will inform the stroke team. I say still within the same day, sometimes, or maybe as fast as possible. But if it comes in within 1 week of history, we would alert the stroke team. And then to the protocol similar for patients that presented with posterior circulation stroke symptoms like vertigo, nystagmus, and imbalance. So that's why we can see that in the NIHH score. If the patient we suspect of posterior circulation stroke, we will still inform the stroke team. Is there any comments from Dr. Ashraf? If you want to comment that question by Anonymous and Isaac Tan?
Sorry, called Dr. Isaac. Yeah. So is the protocol similar patient with posterior circulation stroke symptoms? Protocol, as long as it's a stroke, protocol is the same. But the prognosis of posterior circulation is even worse. So I hope if you have a posterior circulation even faster, you need to tell us. That's in short lah. Basically, yeah, it's different compared to anterior circulation, but the protocol is the same.
Okay, thank you very much. Okay, we just see if there any other questions. Okay, so sorry, 9 o'clock.
You mute again.
Tani